And with this, we move on to our next presenter, Professor REEMA BANSAL. Very interestingly, she is going to talk about leopard skin appearance in patients with exudative retinal detachment. This is what perplexes the retina surgeons because you keep on hearing talks about lymphoma, so she is going to tell us when it is likely to be lymphoma and when something else. Over to you.
Thank you, ma'am, for this opportunity, and a very good morning to all of you. So, leopard skin appearance in a patient with exudative retinal detachment. So the picture that you're seeing is not always the clinical scenario that we may encounter when we see the patient first. So I'm going to show you 3 cases where the leopard skin appearance may be present along with retinal detachment, or it may precede retinal detachment, or it may be seen just after the retinal detachment is resolving. So case 1 was a 47-year-old male who presented with this kind of picture, and he was referred to us after having been seen by multiple centers and with varying differentials, like he was treated as a VKH disease. He was also treated as chronic CSC and Lyme's disease and had been subjected to oral steroids, IVMP, posterior subtenon, Kenacort, and all combinations. So when we saw this patient, we saw that his inferior periphery in the right eye had bullous retinal detachment, and left eye we could see these prominent pigmentary changes, which were of course present in the extreme periphery and likely to be missed on just gross posterior pole examination. So thinking of this as having been subjected to various kinds of treatment and all, so we did the refraction of this patient, and we found that he was found to be high hypermetropic. We subjected him to MRI for the scleral thickness, and his scleral thickness was found to be high. His axil lengths were short in both the eyes. And this is how, when we were observing him and when we were working him up, his right eye retinal detachment spontaneously regressed. And you can see the pigmentary changes now becoming more prominent in the right eye. However, his left eye was not resolving, so he underwent subscleral sclerectomy. And this is the follow-up at 3 years, where you can see the leopard skin fundus being now very prominent on ultra-wide field photography in both the eyes. These changes are much more prominent in the periphery. And this is also in the autofluorescence, where the changes are very prominent, and you can see he's doing fine at 10 years. So to summarize, this case was actually a case of uveal effusion syndrome, where these pigmentary changes and the leopard spot fundus gave us a clue of not treating this patient as what he had been treated before for. Second case was the daughter of this patient, who came with decreased vision in the left eye since 3 weeks, and on examination we didn't find very obvious cause. You can see the peripheral detachment, annular detachment in the left eye, which is shallow, and when we did the fluorescein angiography, all that we could find was some kind of hyperfluorescent leaks, and not enough to tell us of the diagnosis of what's going on. So unless we did the autofluorescence of this patient, and we found that these kind of leopard spot appearance was there in the left eye, and this gave us a clue of what was going on. And by this time, honestly speaking, we were not very familiar with the term familial uveal effusion syndrome to be running in the families. So we did her biometry, and we found that her axil lengths were short. And we got the MRI done for the orbits, and we found that the left eye had ciliocoroidal detachment, which was seen on the fluorescein, along with subchoroidal effusion and mildly thickened sclera. So this was also a case of uveal effusion syndrome, where we could just pick up the leopard spot on the autofluorescence. And since when we did the OCT, we found the right eye was normal, and the bottom scan is the left eye, except some RPE, bumping. We didn't find any fluid. So we counseled the patient and observed her. We didn't do any intervention. So this is how she presented, and 18 months later, when we followed her up, she went on to develop this massive exudative retinal detachment in the left eye. So now that she had massive fluid, we offered her the treatment of subscleral sclerectomy, and she underwent that. So this is how she resolved following the treatment, surgical intervention, and just to compare, this is how she manifested. So this was exudative detachment that developed months after the leopard spot appearance that we saw on the fundus. So case 3, this was a 67-year-old woman who presented with bilateral loss of vision, light perception, and I'm showing the interior segment photographs, which they were not very normal to see on slit lamp examination. And if you carefully see, this was massive retinal detachment, bullous, lying just behind the lens. She was pseudophakic, and right eye, you can see the retinal vessels just touching the lens, intraocular lens. This was the extent of detachment in the right eye, left eye. So we had various differentials and investigations. A 67-year-old woman presenting with visual complaints for almost a month. Both eyes, only light perception. General examination, she was lean, only 40 kgs. So we subjected her to all the tests because we didn't know what's going on. So much of bullous detachment in both the eyes. So we checked her for any malignancy, anything in the body. So all her radiological investigations, including CT chest, ultrasound abdomen, MRI, everything was normal. Hematology workup was normal. So this took us almost a week to complete the investigations, and she was the same with light perception vision. So we didn't want to delay any further. So we subjected her to a diagnostic vitrectomy because thinking of, we wanted to send the fluids for cytology and see what's going on. Is it lymphoma or what else? So her samples, vitreous fluid and subretinal fluid, were all negative for PCR, cytology and everything. So we just gave an empirical treatment for IV methylpred because that is the only thing we could offer. And by the time, 3 weeks, you can see the left eye is now showing the gas bubble. The retina is attached, obviously, for reasons that she had an internal tamponade. And now we are seeing this classical leopard spot appearance with subretinal fibrosis. And this is the time when we realized this is actually a case of VKH disease. So we started her, we gave her 5 IVMP, and she showed a very slow response. As you can see, this is how she was at the beginning in the left eye. And this is how the right eye was there at 3 weeks. So you don't see much difference. So she was responding very slow even to IVMP and oral steroids. So now you can see the tigroid fundus behind the detachment. So this is how she began in the right eye. So 3 weeks, if you look at both the eyes, the left eye is of course better because of the internal tamponade. And at 5 months, you can see bilateral picture of chronic VKH with leopard spot, and this is how we realized that these can present with massive bullous retinal detachment even in an elderly woman, where all our focus was on lymphoma or some kind of masquerades. So this is the OCT on the right eye at beginning, and at 1 year she's doing fine. This is the OCT just after PPV and at 1 year. So this is how she was at the follow-up, and if you compare, this is how she was at presentation. So this is the 2 years follow-up where we had put her on immunosuppression. So you may not have, these are a lot of entities where you have leopard spot appearance in non-exudative varieties like, benign familial fleck retina, and if you go on, the list is endless. So when you have leopard spot fundus, how to proceed? If it is with exudative retinal detachment, think of VKH disease, uveal effusion syndrome, acute lymphoblastic lymphoma, hypertensive choroidopathy, even primary vitreal retinal lymphomas may be with or without exudative retinal detachment, and generally without detachments, chronic CSC, B-dump, Warburg syndrome, and of course many of the flecked retina disorders. So imaging is important in these because clinical examination, we may not always pick up the clues. So all that we need is, of course, good color fundus photographies. Autofluorescence gives you the best clue. Fluorescein angiography and ICG angiography to confirm your diagnosis. And OCT angiography to rule out any choroidal neovascular membrane, especially if you're seeing cases of CSC. Thank you very much.
Thank you, REEMA, for showing those beautiful cases. So you showed us 2 patients like exudative detachment with leopard skin. One was VKH and the other was uveal effusion syndrome. Now for beginners and comprehensive ophthalmologist. Okay, there is a question, I will take that.
Is there any role of B-scan in your first case?
Is there any role of B-scan?
Yeah, B-scan is for, you can do the axis length, of course, and the extent of retinal detachments, and you want to rule out any mass lesion underlying?
Now, in your first case, that case was misdiagnosed by many centers. So initially, they would have done the B-scan and picked up easily effusions and all that.
What you mean is the globe, the axis length of the globe?
No, I'm talking about the B-scan, not A-scan.
So probably the centers that treated this first patient did not do the B-scan, and the exudative detachment was not in the posterior pole. So I think it was in the extreme peripheries, and that was missed. And since we didn't see the detachment in the posterior pole, we don't know whether the patient did present with detachments in the posterior pole to the primary centers.
We can do the transverse B-scan also.
We should, of course, we should.
I put this question other way around. Is there any role of V-scan in your today's, like Dr. Atul Kumar has said, is this industry-driven treatment protocol? Is there any role of V-scan?
Of course, in clinical scenarios, we always do B scans in any patient who presents with exudative detachment, and usually our B scans are combined with A scans because we always pay attention to the axil lengths also.
That's fine. That's the two modalities. So, like old teachers, like if you are having the B scan, then there's no harm in putting. Sometimes we are in very hurry.
No, we always do.
Yeah.
We always do.
Thank you very much.
Yeah. Another question?
Yeah, you may. Yes. You mentioned the imaging modalities. In that, in the list was ICG angiography. Considering that this is a uveal disease, exudative disease, was ICG angiography done in any of these patients? And
No.
If not, why not? And if it was done, do you think it would have helped you closer to the diagnosis earlier?
No, not in these patients, but ICG is mainly required when you have a differential of chronic CSC in your mind and any kind of posterior segment disease where you're not having any clue or you're not knowing, you don't know what you're dealing with. We do ICG angiography, of course, because there is choroidal involvement we have to do along with fluorescein angiography. But since in these cases we picked up the clues on axil lengths, on MRIs, and on autofluorescence, we didn't really need to do ICG in these cases.
But I think if there is a confusion between the diagnosis of UES and VKH, ICG will very easily help you differentiate the two. VKH will show multiple small rounded stromal granulomas, whereas UES or CSR should not show those hypo to hypo lesions. So, though these patients probably did not require because they had good autofluorescence and other clues, but yes, it can be done.
There's also a paper by Bailey Freund where they've described altered choroidal circulation and venous anastomosis which occurs in CSCR.
No, I'm not talking about the choroidal changes in CSC. I'm just talking about the granulomas. The hypo to hypo spots will be seen in VKH. What you are saying is venous overload, choroidopathy and all. We are not talking about that.
Yeah, I was thinking of that for the first two cases, that because there was the uveal effusion syndrome, you would have maybe identified alterations.
I am pursuing that angle very vigorously. Those changes you see in lot more entities, but we still do not know the interpretation. Like how do we manage? Like for me, if I see dark spots for VKH, I know I have to treat it as VKH. If I see anastomosis, I do not know what to do. It just indicates that there has been a pressure on the choroid and you have to look for it, but it does not help in management because there are myriad of diseases which are producing that. Okay. Yes, last question.
A simple thing, looking back into the records of the patient with the non-ophthalmos, or those who have treated the patient first, hypermetropia of such a high degree, it could have made them clinch the diagnosis, at least coming to your center, madam. Seeing the records that this patient is a very high hypermetro.
But you know, many times the axil lengths are not done in comprehensive practice, and this was long time back. This patient presented almost 12 years ago. So the things are changing now with more and more cases of, uveal effusion syndrome picking up like this. So even now it's becoming very common, and VKH is of course the first differential of UVS anyways.
But with this plus 10 or plus 14, I think.
So probably yes, that was missed by the treating ophthalmologist. I'm sure it was not seen.
And
you know,
because
doctor,
these patients.
When we sit in the hall and look at the cases, we all become very wise. You know, it seems, oh, they missed it. But in all honesty, when you're seeing in the clinic, a lot of people miss a lot of things.
I agree with that.
And when these patients present with decreased vision, you attribute that decreased vision to the exudative detachment. Nobody looks at the refractive error.
Secondly, he was treated as CSC. elsewhere.
Yeah.
I don't know, steroids were given despite the fact that the patient is, was having chronic serous chorioretinopathy. I wonder why.
So we cannot answer why the patient was diagnosed as CSE. His records indicated that he was subjected to all the differentials.
We did not give.
Yeah.
Good morning, ma'am. Just one last question. Just one last basic question then. For all the cases with exudative RD when they come to our OPD, should we keep MRI as our first line of investigation also?
No, not as first. We should complete the ophthalmic examination first, including your slit lamp, your fundus, indirect ophthalmoscopy, of course the ultrasound, exhalence, refraction, and do the imaging, autofluorescence, OCT. If the detachment is massive, sometimes OCT is not possible, you're not getting good clues. But yes, subtle detachments, OCTs and autofluorescence and FFA ICG if you have, various differentials in mind.
Thank you. Thank you, REEMA, for very
Thank you.
interesting.